Good morning, everyone, and welcome. I'm excited to be here today to talk about esophageal disorder. This is the first slide, which is our cover slide, so I'd like to start by introducing the topic with enthusiasm. Today's presentation will cover the key aspects of esophageal disorders, including their causes, symptoms, diagnosis, and treatment options. We'll keep it engaging and informative, so let's get started. Let's talk about achalasiocardia, a condition where the esophagus has trouble moving food down properly. The core issue here is aperistalsis, meaning the esophagus loses its normal wave-like contractions, and there's increased tone or tightness of the lower esophageal sphincter, or LES. This happens because of a loss of inhibitory control over the muscles, which normally help the LES relax during swallowing. Now, what causes this? The most common cause is autoimmunity, where the body's immune system mistakenly attacks the nerves controlling the esophageal muscles. Other causes include esophageal cancer, specifically small cell carcinoma, which can be associated with anti-WHO antibodies. Chagas disease, caused by the parasite Trypanosoma cruzi, is another important cause, especially in endemic areas. And conditions like scleroderma can also lead to decreased tone of the LES, along with other systemic features like Lambert-Eaton syndrome. Moving on to clinical features, typically, we see a young woman presenting with progressive difficulty swallowing, which is known as dysphagia. She might also have halitosis, or bad breath, often from food stagnation. Patients usually have trouble swallowing both liquids and solids, which is a hallmark of this condition. Regurgitation of undigested food is common, and recurrent episodes of pneumonia can occur, often due to aspiration of food or saliva. So, understanding these features helps us recognize achalasia early and differentiate it from other esophageal disorders. It's a fascinating condition that underscores how complex nerve control is in our gastrointestinal system. Let's start with the investigation of choice esophageal manometry. As you can see, it typically shows an increased LES tone, which suggests a spastic or hypertensive lower esophageal sphincter. This is a key feature in diagnosing certain motility disorders. Moving on to the barium swallow study, you'll notice the classic bird beak appearance or pencil tip sign. This occurs because of the tapering of the distal esophagus at the LES, indicating an obstruction or motility issue. In the barium enema, the bird beak sign is also observed, which can extend down to cause sigmoid volvulus. This shows how esophageal issues can sometimes be linked with large bowel problems, especially in cases of motility disorders. Now, regarding treatment options, we have several approaches. For symptom relief, anxiolytics like buspirone can help by improving LES relaxation. Nitrates, such as isosorbide mononitrate, are used as long-acting agents to reduce LES pressure. Calcium channel blockers like amlodipine are also effective in relaxing smooth muscle. For more definitive treatment, laparoscopic Heller's myotomy combined with a partial fundoplication is often performed to cut the muscle fibers and prevent reflux. Botulinum toxin injections are another option. They relax the sphincter by blocking acetylcholine release, providing temporary relief. Finally, understanding esophageal carcinoma is crucial. Key signs include the shouldering sign and irregular filling defects seen on imaging, which suggest tumor infiltration. The rat tail appearance reflects the tapering of the esophageal lumen due to tumor growth. Recognizing these features helps in early diagnosis and management. Let's look at this interesting case scenario. We have a 125-year-old female who presents with progressive dysphagia, specifically oropharyngeal dysphagia, meaning she's having difficulty swallowing both solids and liquids as it worsens. Now, what's particularly notable here is that her lower esophageal sphincter, or LES, tone is decreased, which is a key clue. In addition to that, she exhibits some classic signs of scleroderma, such as leather-like skin and Raynaud's phenomenon, which involves episodic vasospasm of the fingers and toes. She also has a history of a hypertensive crisis, which can sometimes be associated with scleroderma-related vascular issues. Now, it's important to differentiate this from achalasiocardia, where you would typically see an increased LES tone. But in scleroderma, the LES tone is decreased, which affects how the esophagus functions. When it comes to diagnosing this condition, the investigation of choice is the anti-topoisomerase AB, also known as anti-SCL70 antibody. The presence of this antibody supports the diagnosis of scleroderma, especially in cases with these systemic features. So, in summary, the key points are recognizing the clinical signs of scleroderma and understanding that the LES tone is decreased here, which helps differentiate it from achalasia. The anti-topoisomerase antibody test is essential for confirming the diagnosis. All of these pieces fit together to guide us toward the correct diagnosis and management plan. Let's walk through this case scenario. We have a 30-year-old individual with a history of alcohol use, specifically binge drinking. He's presenting with recurrent vomiting and retching, which are important clues. He's also experiencing chest pain and episodes of syncope, which can be quite alarming. On examination, there's subcutaneous emphysema, so you might notice crepitus below the skin, which indicates air escaping into the tissues. His vital signs show a heart rate of 120 beats per minute and a blood pressure of 90/60, suggesting he's hypotensive and possibly in shock. A key point here is Mackler's triad, which includes chest pain, vomiting, and subcutaneous emphysema. This triad is highly suggestive of Boerhaave syndrome, an esophageal rupture, often following forceful vomiting. Now, the diagnosis in this scenario is Boerhaave syndrome. It typically involves a rupture in the lower third of the esophagus, usually posteriorly. When this happens, chemical mediastinitis occurs due to the leakage of esophageal contents into the mediastinum, causing chest pain. In some cases, especially if the rupture occurs during procedures like esophageal instrumentation, the tear might be in the cervical esophagus. To confirm the diagnosis, a CT scan of the chest is the imaging modality of choice, as it provides detailed information about the extent of the perforation and mediastinal involvement. Additionally, a chest X-ray can reveal abnormal findings like pneumomediastinum or subcutaneous emphysema, and it's crucial to continue monitoring the diaphragm and the thoracic cavity overall. Understanding these points helps us recognize the importance of rapid diagnosis and management in esophageal ruptures, which can be life-threatening if not promptly treated. Let's look at this case of a 30-year-old woman who has a history of alcohol use. She presents with epigastric pain and nausea, but interestingly, she hasn't vomited yet, although she's willing to vomit. The key here is that the doctor notices she can't pass an NG tube, which is a significant clinical clue. The probable diagnosis in this scenario is stomach volvulus, which is a twisting of the stomach that can cause obstruction. Now, there are two main types of stomach volvulus to be aware of: mesentericoaxial and organoaxial. These refer to the axes around which the stomach twists. A classic feature to remember is Borchert's triad, which includes epigastric pain, nausea without vomiting, and failure to pass an NG tube. Recognizing this triad can really help in making a prompt diagnosis. For investigations, a chest X-ray can provide initial clues, but more definitive imaging like a CT scan of the abdomen with oral contrast or barium contrast is often required to confirm the diagnosis and assess the extent of twisting. When placing the NG tube, it's crucial to do so in a conscious patient who is sitting upright with their neck partially flexed. This position helps protect the airway and reduces the risk of aspiration. As for treatment, surgical repair is generally necessary to untwist and fix the stomach, preventing recurrence and potential complications like ischemia or perforation. So, in summary, recognizing the clinical signs, understanding the types, and knowing the appropriate investigation and management steps are essential in effectively handling stomach volvulus.